as time is tight, we're going to launch straight into the first pilot presentation. We have about 10 minutes for each talk and 2 minutes for questions, so I'll try to keep that on track. Ojas, why don't you take it away?
Awesome. So may I start sharing my screen then?
Sure.
So my slides are visible fine, right?
Yes.
Awesome. Yeah. So good morning, everyone. I'm sincerely grateful to have received the Pilot Award. Thanks so much for providing us with the opportunity to present our work at today's IMDS Symposium. So with our work, we try and ask a much broader question. So we see a plethora of robust deep learning models for various healthcare applications that have demonstrated encouraging results in providing improved diagnostic outcomes, early intervention strategies, and well-tailored patient-specific management options. Now, especially in the field of radiology, for critical tasks like breast cancer screening, the performance of AI algorithms for medical image analysis is on par with that of radiologists. Moreover, studies have shown that combining AI outputs with radiologist interpretation has also led to substantial performance enhancement for breast cancer screening. Considering the generalizability of these deep learning models, many AI tools for breast cancer screening have in fact received FDA approvals. However, studies have also demonstrated that the performance of AI models can vary across diverse subpopulations, leading to disparities in healthcare outcomes. Essentially, AI models can succumb to reduced performance in new clinical settings and pose challenges to achieving desired population level outcomes. The underperformance of these overparameterized deep learning models can cause concerns for misdiagnosis, overtly affecting patient safety. Thus, before health institutions can confidently use one of these AI algorithms in their radiology workflows, it is crucial to develop infrastructures that can effectively validate the performance of these models prior to their clinical adoption. However, However, rigorous external validation of AI algorithms is impeded by numerous challenges. On one side, we have these amazing, robust, generalizable deep learning algorithms, and on the other hand, we have patient data. Now, due to intellectual property concerns, algorithm vendors may be hesitant to share their commercial AI models with medical centers for independent validation before they commit to a purchase. Moreover, per HIPAA guidelines, to safeguard the privacy of patient data, academic institutions cannot provide imaging data to AI vendors for model validation. Moreover, healthcare organizations need to decide between on premises and cloud based infrastructures. Now, adapting an on-premises setup to provision for the diverse computational specifications of multiple models can necessitate procuring additional hardware resources and entail configuring them to be compatible with the existing clinical setup. In contrast, the configurability of cloud-based storage and computational environments, their cost-effective setup and maintenance, built-in network security, and information recovery services, and rapid acquisition render cloud infrastructures as an appealing choice for deploying and rigorously validating AI algorithms on large datasets. Now, to address these challenges, healthcare organizations can outsource the work of evaluating AI algorithms. However, procuring third party services can be even more expensive and can entail cumbersome legal and technical challenges when it comes to providing access to patient data. Thus, we need a framework to establish robust cloud based infrastructures. And to address this limited technical guidance, I aim to equip healthcare institutions with a framework that can help them perform external clinical validation of AI algorithms prior to their integration into clinical workflows. And thus, I would like to present our work called ClinVal AI, which is an open source, cloud agnostic, unified framework for establishing robust infrastructures to validate AI algorithms and further customize its capabilities for the clinical validation of AI algorithms for medical imaging applications. Now, to address the patient privacy and intellectual property concerns, we adapted the model to data paradigm, which was developed by UW researchers to validate AI models on private biomedical data. Essentially, cloud infrastructures and containerization techniques form the foundation of this framework. So, Rather than providing direct data access to the vendors, the Dockerized AI algorithms are uploaded to the cloud host as containers that encapsulate the deep learning model, their dependencies, and other configuration settings which are needed for model validation. We adapt the framework to support license files. Now, what it allows is that it helps the AI vendors to control access to their models. Thus, our work enables health institutions to preserve patient data within a firewall and run models on medical imaging exams without providing vendors direct data access. So, coming back to the framework, we see that we have these three pillars, which essentially represent three workflows. So, let us go to the first workflow, which is the data ingestion workflow. Data ingestion workflow comprises of two mechanisms. The first is the input auditing mechanism, and the second is the data standardization mechanism. So the input auditing mechanism, what it does is that it verifies whether data can be processed and are aligned with the model's prerequisites before initiating the scoring process. It checks for corrupted files, it checks whether DICOMs are missing pixel data, and so on and so forth. And the standardization mechanism uses the outputs of the auditing mechanism and takes necessary action so that the files are ready for models validation tasks. The second is the scoring workflow, which essentially comprises of three parts: the data restructuring, algorithm inferencing, and score extraction. The data restructuring essentially ensures that the data is ready for model validation such that it is restructured in the fashion that deep learning models can process it. The algorithm inferencing then essentially customizes the deep learning model's Docker image such that inferencing can take place. And after the models have processed the data set, the score extraction mechanism then helps us extract the final outputs of interest, which can be image, exam, or patient level scores. Finally, we have the output processing workflow, which comprises of two mechanisms: the output auditing mechanism and the output aggregation mechanism. The output auditing mechanism performs the essential task of verifying if results have been produced for all the inputs and if the generated files comply with the algorithm's expected outputs. And the output aggregation mechanism systematically uploads data from the audited results, supplementary files, and logs to a relational database to streamline analytical pipelines. So thus, we saw that we have these three workflows that can perform the task of external validation. But is ClinVal AI actually usable and reliable? And to that end, we evaluate its utility by using our ClinVal AI-based infrastructure to externally validate the Mirai algorithm for breast cancer risk prediction, which has demonstrated generalizable performance across datasets from three continents. We see that when evaluated on the UW medicine dataset using our infrastructure, the Mirai algorithm demonstrates performance levels which are comparable to the previously reported results. Moreover, we were also able to perform stratified statistical analysis to see that it demonstrates generalizable performance across subgroups defined by age, race, and breast density. We also did calibration analysis, which was not done by previous papers, which helped us understand that when exams with cancer diagnosis within 6 months were excluded, the calibration metrics substantially worsened. Overall, Mirai was significantly overestimating risk at the earlier timeframes. So with this, we see that ClinVal AI definitely has the potential to help health institutions externally validate deep learning models. So to conclude, in terms of the clinical impact, our work equips health institutions to assess the generalizability and investigate latent biases of these algorithms before their clinical translation. It helps identify latent biases. Now, it also helps deep learning. It also helps health institutions to periodically retest performance and analyze variations in model performance vis-a-vis data drift and model drift. Vendors can analyze performance based on detailed findings from the results communicated by our framework. A streamlined feedback mechanism can support targeted fine-tuning efforts. And finally, ClinVal AI can pave the way for studying the capabilities of AI algorithms in optimizing clinical workflows. Our work thus provides the opportunity to reliably understand the real-world performance of deep learning algorithms in healthcare settings and their impact on patient care, health, and safety. With that, I would like to sincerely thank the University of Washington Institute of Medical Data Science for providing us with this opportunity, and I'd like to take any questions. Thank you.
Thanks very much, Ojas. So we have 3 minutes for questions. I don't see any in chat right now. So I'll open with one while others perhaps formulate theirs. So I had a question around the idea of validation, which was spurred by one of your earlier slides where you showed the performance of radiologist with the ensemble model has this area under the curve that sort of exceeds all of the model alone. So I was wondering if you thought about a way in which a human AI team might be evaluated within the context of this framework.
Yeah, so essentially what it implies is that we would have to, like, in addition to giving the scores that the deep learning models generate, we could also have like the scores or the interpretation of a radiologist, which is also passed in an ensemble setting, such that there's a weighted averaging that happens for the radiologist interpretation and also the deep learning models outputs. And I think, and with that, we can essentially scale our framework to validate the team's overall interpretation per se.
Thanks very much. I don't see any other questions in chat, so I think we should move on in the interest of time to the next presenter, who is Agam Chopra. So, Agam, if you could please take control of the screen. Thanks very much for that presentation. It's very important work.
Thank you so much. Okay, are you able to see my screen?
Yeah.
Awesome. Okay, so I'm Agam. I'm a PhD student at Dr. Kurt's lab. I will be taking over for him today. So I'm presenting our work on synthesizing tau PET from multimodal MRI for Alzheimer's disease detection using a novel distangle quantized variational autoencoder. So just to introduce the problem, about 7 million US citizens above the age of 65 suffer from Alzheimer's disease. AD has currently no cure, so early diagnosis is really imperative for better patient outcomes. The current pipeline for AD diagnosis involves a multi-step diagnosis process, which includes cognitive evaluations, followed by MRI or CT scans, which is followed by blood tests and PET scans. PET scans are especially important for diagnosing and tracking disease progression throughout the patient's AD. And so one question that we asked was, what if we can integrate a predictive PET scan using the MRI modality only during the early steps of diagnosing AD? So one way to do this is by using deep learning-based algorithms, such as an encoder-decoder-based model. So what is an encoder-decoder model? So majority of computer vision models and language models tend to use an encoder, which compresses and extracts relevant information for a particular synthesis task, and a decoder that converts that to the target domain. So certain variants of encoder-decoder models that I'm sure you guys are familiar with are autoencoders, variational autoencoders, and units, especially in medical imaging. Units are particularly good because they use skip connections, which greatly improve spatial reconstruction. But there are some caveats. So the limitations with VAEs, which will be the focus of our talk today, is they're unable to preserve anatomical details because of the way the loss function is, particularly the KL divergence term in the loss function. Additionally, variational autoencoders represent the latent space in continuous form, which is not actually representative of, or might not be representative of real data sets. For example, an apple and an orange are discrete objects. They cannot be interpolated between each other. I'll talk a bit more about it in the next slide. And for autoencoders and units, the way they learn their latent space is not explainable, and it's really bad for downstream generative tasks, like, for example, diffusion or GANs. So one way to mitigate this is by using vector quantization. So this is a framework that was introduced by Microsoft a couple of years back. So vector quantization discretizes the latent space by learning only a set fixed length of structured codebook embeddings. This helps preserving in anatomical details. So I made like a little analogy on the top right using a chicken and an egg. So in a VAE, you will see a continuous latent space, which causes interpolation and might result in generated features that are not realistic. But in a VQVAE, quantized latent space, you will always have discrete representations for certain features, ensuring that the generated features are realistic. So this also allows us to learn sparse representations in the latent space, which might, in some cases, lead to simpler models being able to learn more complex relationships. Um, Additionally, VQVAEs, so I have a model diagram on the bottom right as well. Uh, VQVAs can be really easily integrated into other generative tasks and tasks that relate to text embeddings, for example, text to image or something like that. But there's still a problem with VQVA. It is more explainable, but how can we make this more informative during training itself? So in information theory, there's a concept of partial information decomposition, which decomposes the generated feature in terms of how the input source information interacts with each other. So under this framework, under a three variable framework, our generated feature, which in our case would be a PET scan, can be explained in terms of unique information, which is the information uniquely associated with T1 and flare imaging and no information overlap. Redundant information, which generally tends to be structural information. So there's some structural overlap, information overlap between T1 and flare. And then complementary information, which is new information that explains the generated PET features in terms of the interaction of T1 and flare. So this helps us to quantify how the information that we see, the PET features that we see arises in terms of T1 and flare and what interaction they might have. This also helps us simplify a downstream task by selecting only the features that are the most important. So for our project, we put VQVAE and partial information decomposition into a single framework, training framework. And this is inspired by VQVAE2 model. So our model consists of 3 parallel VQVAE models. Each of them, I know it looks very complicated, but it's pretty straightforward. Each model learns redundant, unique, and complementary information respectively. The way we enforce this distanglement of information is using mutual information loss terms. I won't be going too much into the detail of that, but to help our models learn this even more, we also have these classifier models that for the unique, the classifier model encourages a model to learn features that help our classifier distinguish information arising from T1 and flare. Whereas in the redundant, our classifier encourages our model. We actually incorporate a gradient reversal layer before our classifier, so our model is encouraged to learn similar information for T1 and flare, which will lead to confusion for our classifier's outputs. The training process is quite tedious as we have a lot of hyperparameters that we need to tune. And this is something that we're still trying to figure out. So to evaluate a model, we use 2 major metrics, image quality metrics and tau localization. So for image quality metrics, basically we use standard SSIM, structural similarity index, which measures the global structural similarity of our input and ground truth image, and peak signal to noise ratio PSNR, which measures the voxel-wise image quality. For tau localization, we used a really simple framework for now, which basically downsamples our generated images, takes the average of a certain voxel region, and then computes the top 10% contrast regions. And then we can reframe this problem as a multi-class classification problem. So we use ADNI3 dataset and OASIS3 dataset to train our models. These compose of 3D MRI and T1 flare and tau PET paired images. There were about 600 training samples and 80 validation samples. So quickly going over some results that we got. Our VQ models perform significantly better compared to the VAE models, as seen in the graph and the tables. And our completed VQ model performed slightly better than all our compared VQ models. Although the performance of our redundant, unique, complementary, and full model is quite similar, which might indicate there's some information leak going on. I personally think that this might be because of our loss function not being properly tuned and our reconstruction loss being too powerful during training. So it's emphasizing the reconstruction over disentanglement of information. Although there is still some level of disentanglement, we can visualize that, and I'm working on that right now. Um, but another thing we can observe is that for image quality metrics, the redundant features seem to be the most important for reconstruction, which makes sense because intuitively this will consist of structural information, right? Which is important for reconstruction. And for identifying the top 10% tau contrast regions, the unique T1 information seems to be really important. I'm not a radiologist, so I don't know if this is what we want to expect, we would have expected, but this is something I thought was pretty cool. So there's still room for improvement, obviously. We are currently working on optimizing our network further and our loss functions as well. And the next step that I want to do is implement this pipeline into a transformer-based diffusion model, and maybe try implementing this as a unit model as well. And I also want to conduct some additional baseline tests just for sanity check. And instead of using the top 10 tau classification, implement a BRAC staging-based classification metrics. And with that, I'm open to any questions. Thank you so much.
Thanks very much for that talk. I think that like the overarching idea of using machine learning to infer a more demanding, like resource-intensive evaluation from a more accessible one is really interesting.
Yeah.
I don't see any questions in chat, so I encourage the audience to please ask some questions in chat from here on. But I was wondering myself about your model. If the goal is to develop discrete latent spaces, if you directly measured the similarity between the resulting latent spaces, or if that's possible.
Right. So our discrete latent space. So initially we used a single codebook. So there were some issues implementing that that didn't really work out, basically. We were not able to impose the discretization in terms of information distanglement in a single codebook. So we ended up using 3 different codebooks for each of the model. So each model has its own codebook, which kind of helped out with distangling their information. I hope I answered that question.
Yeah, getting there. I think it's a longer topic than we have time
Okay.
to get to this 2 minutes, so but maybe we can pick it up. But again, in the interest of time, we're at 12 minutes, so I think we should hand over the reins to the next presenter, who I believe is Meliha Yetisgen.
So let me share my screen. Can you see my screen?
Yes.
Yeah, okay. So the title of this talk is Characterization of Long COVID Patients Primary Care Clinic and Long COVID Specialty Care Clinic with NLP. So this project, I'm presenting this project on behalf of Wei Peng, who was a PhD student in my lab who graduated last year, and he's a postdoctoral researcher at Yale. For this project, he was supervised by Carrie Stevens and Nikki Gentile from Family Medicine, and none of these people could be here, so I'm presenting their work on behalf of them. So in terms of motivation, long COVID is a condition in which a patient continues to experience lingering symptoms such as brain fog or fatigue more than 3 months after recovering from COVID. So they identified 2 gaps. The first gap is existing literature of long COVID primarily relied on only ICD codes to represent the symptoms of the patients. And in the second gap, there was a resource allocation problem to identify more severe cases and mainly referring them to specialty care. So there are two aims in this project. The first aim is characterization of demographic and symptomatic differences between long COVID patients in the primary care versus specialized care, and also model development to identify more severe cases. So this is the main, main data set, patient cohorts. There are three groups of patients in this study. The first group is primary care group, of course. There are 241 patients in this cohort within that time frame. These are long COVID patients visiting primary care clinics only, so they represent the less severe cases. The second group is the specialty care group, which contains 904 patients. These are the patients attending the UW long COVID specialty clinics. And there's a disparity between the numbers because most of these patients are actually referred to UW medicine from outside of the system. And the third group is the retrospective specialty care group, which contains 317 patients. These are the subset of the severe specialty care group, which represents more severe COVID cases, but they are with UW's patients. They have been seen primary care first in UW and then mainly referred to specialty care group. So each patient was represented with demographic information, all their ICD codes for that time frame, and also clinical narratives. So what Weipeng did was he created all this corpus, the notes, and collected them. He mainly captured the symptoms with ICD codes, but he also processed all the clinical notes with a system developed by my lab. Mainly what the system does is it extracts all the symptoms with detailed attribute mentions in the clinical narratives. So these are the papers associated with this extractor, which is mainly based on deep learning and also the most recent LLM extraction approaches. So after he applied all this to these clinical notes, he mainly worked with the clinical experts in the study to mainly create a symptom list of 44 long COVID risk factors. And all ICD codes were filtered with this list, and all NLP extracted symptoms were filtered with this list. He only used the symptoms that are positive mentions, so all the negated or hypothetical or possible symptoms were removed from this analysis. So in the first aim, mainly he used two groups, primary care group and specialty care group, to differentiate the differences between these two populations. And when we look at the demographics, gender was the same. Age for specialty care group, it was surprisingly younger actually. And when they look at the insurance, they saw that specialty care group has more commercial insurance. So meaning that more people were insurance go to the specialty care when compared to primary care. So in terms of racial and ethnicity, they found that higher prevalence of white individuals in specialty care and lower prevalence of Hispanic and Latino individuals in specialty care. So when we look at the ICD versus NLP extracted symptoms, this is not a very surprising finding because it's a known fact that symptoms are underrepresented in ICD billing codes. So when we combine them, it's mainly patients could be represented better from their symptoms. In one example, for fatigue, when you look at ICD alone, only 23% of the specialty care patients identified with fatigue. But when you add the NLP extracted symptoms, this number increases to 96%. So they also compared the specialty care versus primary care. These are the 10 top mostly mentioned symptoms in the clinical narratives and those ICD codes. So as you can see, for example, for specialty care, fatigue, headache, anxiety, shortness of breath, fever, lightheadedness, chills, and weakness were more prevalent compared to primary care. But I think this study needs to be enriched with the combinations of these symptoms to see that, how they interact and if there are any patterns between specialty care versus primary care. So right now, it's only in this preliminary analysis, it's only single features, single symptoms. So in terms of conclusions, this is the first internal long COVID data set. In a way, like it's a very valuable resource to understand what's going on with these long COVID patients. NLP symptom extraction provides a more comprehensive picture, and statistical analysis revealed that there are actually symptomatic differences between the more severe and less severe cases. And this actually is fed into this analysis, feds into AIM-2 model training to identify more severe cases. In AIM-2, Wei Peng used group 1 and group 3 because we want to have like primary care representation for both of them. The task is to identify by only looking at their primary care records and ICD codes to determine which ones needs to go to specialty care. So for model training, the test split is 50-50. These are very preliminary results, and he mainly represented the model with ICD codes and ICD plus NLP symptoms. And for feature encoding, he used one-hot encoding. He did lots of like hyperparameter tuning for all these classification approaches. And then for the results, like I'm just like presenting the best performing system, which is logistic regression. In terms, even with a simple modeling approach, like we could get really high recall, which is more important, and kind of relatively lower precision. And when Wei Peng looked at the false positives, he actually identified that some of those cases are actually severe cases, but just didn't end up in the specialty care clinic. So in terms of conclusion, like logistic regression in this case, in this very preliminary results, effectively identified this high-risk long COVID patients with a really high recall. So the top 10 features that has the greatest impact are 8 of them are NLP extracted symptoms, 2 are ICD extracted symptoms. And these preliminary results are promising actually to identify more severe cases compared to less severe cases, but like more studies needs to be done actually, like to mainly improve the performance on this classification. So yeah, thank you, and questions.
Thanks, Meliha. It's a very compelling demonstration of why we might want NLP extracted features from our clinical notes, right?
Yeah, especially symptoms. Yeah.
Yeah. So I don't see any questions again. Oh, here's a clarifying question. So the question is from Lucy, and I'll go back up to the previous one, is whether the features were extracted from admission time notes.
So these are only mini primary care notes. Like these are like, you can perhaps like consider them admit notes, but they are not like, these are not inpatients. These are outpatients.
Thanks. And then there's a previous question from Kate on how the algorithms account for documented barriers to care, such as language barriers or racial inequity. And I guess the context must be in terms of who receives specialty care, perhaps.
Well, they looked at demographics. This is not a domain of mine. I'm just like I cannot really, like, if Kari was here, like she could answer this question more comprehensively. But when they looked at the racial disparities, they found that like more white people were attending to specialty care, and but from clinical note perspective, we only use symptoms, and I don't think symptom documentation has really a huge impact, like from that aspect, like from racial aspect.
Thanks. We have time for one more question, and I know everyone, you have your hand raised. So if you type in your question, I'll try to fit it in after I ask this next one in chat. So the question from Brody is, did you look at what the human error rate for similar feature extraction was, like inter-clinician concordance, or I guess we'd call that inter-annotator reliability, I suppose?
So like inter-rater agreements for this, like I have like extensive work in the cancer domain, COVID domain, and other domains for symptom extraction. And we always create a gold standard. And also there is, of course, like problems in terms of like symptom extraction, right? Like I'm sorry, inter-rater agreements when they label things. And for these data sets that the model was trained on, like the inter-rater agreement was around 86%. And all these models like were matching that. So there's always like, of course, error introduced by these, but with symptom labeling, the inter-rater agreement was quite high.
Thank you.
Okay.
We do, because you were so efficient in your talk, we have time for one more question, but
Sure.
just one, sorry, Jim. So question from Abraham Flaxman. What can you tell us about what ICD codes are getting in or not getting in based on notes? Like what are the ICD codes missing?
So the ICD codes are missing in terms of like, so ICD codes are not meant to capture like symptoms, right? They are billing codes. So for example, for nausea, right? Like it's not like some doctors like report that, some doctors don't report that, but when we look at the clinical notes, we usually see them there. So it's kind of, that's why ICD codes lack symptom documentation that much, or like high fever, or things like that. They are not usually, they are in the ICD codes, but they are not entered to the system. They are always documented, like pretty much documented in clinical narratives. And does that answer the question? So it's kind of like a kind of clinical workflow thing, in my opinion. Like they are not meant to like represent the symptoms from billing purposes. So
thanks very much. So with apologies to Jim, I think we need to move to the next presenter in the interest of equitable distribution of time. So the next presenter is Savannah Partridge. So if you could please take up the baton.
Actually, Anam Kazaruni is going to be presenting from our group. She's the postdoc lead on the project. I'll hand it to Anam. Thank you.
Thank you.
There we go. Yeah, you all can see and hear me okay?
Yes.
Okay, cool, great. So just like Savannah said, I'm a postdoc in Savannah's lab, the quantitative breast imaging group in the Department of Radiology. And our pilot grant was in collaboration with Dr. Shachi Mittal in the Department of Chemical Engineering. So some background: triple negative breast cancer is an aggressive breast cancer subtype associated with poor patient prognosis compared to other subtypes of breast cancer. And those with locally advanced disease receive what's known as neoadjuvant chemotherapies. This is just chemo delivered prior to surgical resection of the tumor. And the challenge is that there's variable response to neoadjuvant therapy. 30 to 50% of patients achieve a pathological complete response where there's no tumor at the time of surgery. And with recent immunotherapies, that number's been bumped up to 60%, but still variable, really highlighting the need for biomarkers to predict who's going to respond to therapy versus who may be candidates for therapy escalation to help us optimize patient outcomes. So there's been growing appreciation in the last few years of the immune microenvironment and its role in therapy response in cancer. So on the far right here are two H&E images to show you low versus high immune infiltration in breast cancer. The immune cells are these dark purple dots throughout. So these are known as tumor-infiltrating lymphocytes, and in the stromal regions of tissue, these are stromal tumor-infiltrating lymphocytes, or stromal TILs. And what recent research has shown is that patients with increased levels of stromal TILs, they have better response to neoadjuvant therapy. So as part of the preliminary data for this project, we looked at our own UW patient data and found that patients who achieved PCR had higher stromal TIL levels. We are in the Department of Radiology, so a lot of what we work with is breast MRI, and that allows us to get 3D whole tumor metrics of the tumor microenvironment. So one metric is this functional tumor volume. We found that patients who achieve PCR have a lower amount of this viable or functional tumor volume. Ultimately, we were interested in if we combined these two pathology and MRI-based measures, can we improve our prediction of pathological complete response? And our preliminary data was encouraging and said, yes, these might be complementary measures and could improve our prediction of response. Just a brief note, these are all prior to initiation of neoadjuvant therapy. So before they even start chemo, being able to predict how they'll ultimately respond. So one of the limitations of the current way that we assess stromal TILs is that it's qualitative. Pathologists will read a slide, and that inherently makes it very subjective. the metrics are very coarse. They're either like 3 categories, like low, medium, high, or a little bit more granular in deciles, so 0 to 10%, 10 to 20. So there's a lot of variability, and then there's this opportunity for reader bias as well. In recent years, there's this growing field of computational or digital pathology where pathology slides are scanned and AI algorithms are applied to automatically and quantitatively characterize the different cell populations present in the tissue. So the goal for our pilot award was to integrate digital pathology features and MRI features to characterize the immune microenvironment in triple-negative breast cancer to improve predictions of patient outcome. So there are sort of 3 broad aims to this study. The first was to just develop and validate an AI model for automated quantitation of stromal TILs from H&E data. The next was, once we had those metrics in hand, can we identify immune signatures that are associated with therapy response? And then finally, taking those metrics, can we integrate them with MRI features to improve our prediction of patient outcome? So the vast majority of our first year of funding has been on this first aim. It was a Herculean effort done by the graduate students in Dr. Shachi Mittal's lab. So they worked collaboratively to develop this pipeline called TILSEG, which is short for TIL segmentation. So we previously we had collected this retrospective cohort of triple-negative breast cancer patients who underwent neoadjuvant therapy, collected all their diagnostic biopsy slides and scanned them. So we have these whole slide H&E images. The next step is this tissue area annotation, and then dividing these images up into patches. So that's an example patch is shown here. Then as part of Dr. Mittal's prior work, they applied a 3-class tissue classifier that splits the tissue into stromal, epithelium, or other tissue. And this allows us to focus in on stromal regions within the tissue area, within the tissue patch. And then applying some more new tools here for identifying nuclei, and then some filtering based on size and other features to identify TIL nuclei specifically. We get these final stromal TIL contours throughout the patch. And then this is applied across the entire whole slide image. So this pipeline development was a large effort for the past year, and it was very iterative. So we worked collaboratively with our pathologist collaborator, Dr. Susie Dintis, to make sure that we are segmenting what a pathologist would call a stromal TIL, and learned a lot through that process. Ultimately, we were able to apply this to a majority of our specimens and then compare our qualitative pathologist-based TIL score to our quantitative TILSEG TIL score. And we see some good agreement, which is really encouraging. So this is still something we're working on and iterating to improve further. But in the meantime, we started looking at associations with neoadjuvant therapy response. So looking at our quantitative TIL score versus PCR and recurrence-free survival, as well as developing new metrics to look at the spatial distribution of immune cells versus tumor cells, and if those metrics are predictive of patient outcome. Before we got snowed in, I was going to plug, and maybe we'll eventually have a poster symposium, which would be great, to plug Lisa Carr and Khan Ha's poster, where they were going to show some of these results. Hopefully we can have an opportunity to share those at a later date when the weather's better. Ultimately, we want to take those pathology metrics and combine them with MRI. So we began to do some of this work. And one of the great parts of all of this pilot data was that we were able to submit an R01 that's currently under review that really further explores the quantitative computational pathology and integrating with breast MRI further. And so with that, I'd like to thank the Quantitative Breast Imaging Lab, and also acknowledge these graduate students right here from the Mittal Research Lab for their efforts in developing this pipeline, and then our clinician collaborators who, without, we really wouldn't understand the best clinical questions to be asking, and then ensuring that we're doing the work correctly, essentially. And I'll take any questions.
Thanks very much. So we do have a first question in chat from John. and a compliment. Nice talk. So the question part is that the slide showing initial good agreement between quant and qual has a lot of outliers. I realize this is early work, but are there any thoughts on these outliers?
Yes. So some of this, I think, has to do with the way that pathologists evaluate stromal tills is not just all the tills in the stromal region, which is what our initial thought was based on the description, but it's really the regions that are close to invasive tumor within the specimen. So now that's part of the iterating that we're developing further, is looking at regions where we see more invasive cancer, and then from a distance within, some millimeter distance within that, quantifying the stromal tills in that area, as opposed to like a whole tissue assessment. And then also some of this is just the coarseness of the metric on the pathologist side. This first bin is really 0 to 10%. And so it aligns, but there's a lot of variability within that area there.
Thanks very much. Yeah. So we do have time for another question, and nobody has jumped in, so I'm going to ask one. So I was wondering about the overall design. It seems as though that what you've done is deliberately abstract from images features that would be meaningful to pathologists, and then use those as predictors rather than try to predict treatment response from the images themselves. And I was wondering if that was like the motivation for that design decision. Was that model accuracy or trust in the model, or something else?
I think it's based on preliminary findings. There's a lot of established clinical work using the pathologist reads of these stromal tills, and then it's now being integrated into, or clinical trials are starting to be designed around this pathologist metric of stromal tills. So there's some clinical appreciation that these are meaningful prognostic markers, but there's this inherent variability. So part to improve our prediction, but part to also reduce this bias and variability by using just by developing a computational tool to assess stromal tills.
Got it. Thanks very much. Mm-hmm. And I think with that, there are no further questions, so we can hand over to the presenter of the next talk, who I believe is Yetisgen.
Hi, can you see my screen?
Yes.
Great. I am Yetisgen. I'm a PhD student in the UW Information School in Lucy Lu Wong's lab. This research was conducted in a collaboration with pulmonologists and researchers from UW Medicine. The primary topic of this research project is invasive mechanical ventilation, which is a treatment applied to save the lives of patients in intensive care units who are experiencing respiratory failure. As a patient's condition improves and they are able to begin respirating on their own, a key question that clinicians have to ask is, when can this patient be safely extubated? If they're too late, this has increased risks of complications such as pneumonia or infection, whereas if they're extubated too early, then we risk extubation failure, which is where a patient has to be reintubated, which results in excess morbidity and mortality for this patient. So the way that we frame the question that we're trying to answer in our research is essentially, will a patient need to be reintubated? So we're trying to see, after a patient is extubated, do they lie along this top track, in which case they are successfully discharged without further invasive mechanical ventilation, or are they eventually reintubated, which bears the risks that we have described on the previous slide. And we, in our research, are designing machine learning risk assessment tools to be applied after a patient has assessed the patient's physiological readiness for extubation, but before the extubation itself occurs. So we are designing tools that can provide risk scores for patients at this point in time, which can help inform clinicians about whether they should apply additional treatments to help prevent the risk of extubation failure. So currently, there is an existing risk assessment tool used in UW clinics. It takes the form of essentially a checklist of about 20 different factors. If a patient meets 2 of these 20 factors or more, then they are deemed high risk and they receive additional precautionary measures prior to extubation, such as the administration of bedside anesthesia, which can help lower the risk of extubation failure. However, this tool is pretty brittle in that it only incorporates a small number of variables and only as binary features. So to address these concerns with the existing tool, we are developing machine learning models that can incorporate a wider array of relevant variables that might be useful for predicting extubation failure risk and may be combined in different functional forms rather than simply meeting a certain number of fixed criteria. Ideally, the models that are developed in this process will be interpretable in a similar manner to the current extubation readiness tool, so clinicians can understand why a patient was predicted to have a given risk level. And to assess the performance of models we train, we are comparing to the pre-existing tool. The cohort enabling the training of these models is about 10,000 encounters who received invasive mechanical ventilation at University of Washington ICUs between 2021 and 2023. We filtered this cohort down to about 3,700 final patients, and this data set includes both clinical notes and tabular data for each encounter. So we do have a wealth of data about each patient. One unique factor about this data set is that it was collected entirely after the onset of the COVID-19 pandemic, which means that we have a high proportion of patients who with particularly severe conditions, in contrast to prior research in this domain of extubation failure prediction. Just a bit more about our cohort. About 2/3 of the population is male, similar proportions of white patients and patients younger than 60 years of age. When training our models, we included predictors such as diagnoses available at admission time, labs prior to the point of extubation, similarly like medications, vitals, and ventilation settings before extubation time, and other predictors that have been shown to be associated with risk of extubation failure in prior research, such as the length of the initial ventilation. We operationalize the outcome of extubation failure as death or reintubation within 7 days of the initial extubation. And we developed a number of different predictors over this data, over this structured data in our data set, including basic logistic regression models, gradient boosting to assess whether there are important nonlinearities that we can take advantage of, and also training survival analysis models such as Cox proportional hazards to assess whether attempting to model the time to reintubation for each patient allows us to learn more about patient risk than simply treating extubation failure as a binary outcome. We used 8-fold cross-validation, and the metrics we report for each model are currently the average across the validation folds. So some initial takeaways from our model are that the models we trained do outperform the current readiness exam for most metrics. So in particular, the gradient boosting model that we fit attains generally the best metrics of any of the models that we trained. It attains similar sensitivity to the existing readiness exam while having much better specificity, positive and negative predictive value than the current model. One particular metric of note is that among the highest 10% of risk scores assigned by this model among these patients, roughly 75% of these patients were reintubated, which compares to about 25% of the cohort experiencing extubation failure overall. And so this suggests that this model might be useful for picking out a subset of the most high-risk patients and being able to alert clinicians about at least this subset of patients who did end up experiencing extubation failure in practice. The survival analysis models that we trained performed similarly to their non-survival analysis counterparts. So for instance, the gradient boosting survival analysis model we trained performed similarly to the non-survival analysis gradient boosting model. And some initial takeaways from this work are that the features that we identified as predictive were in alignment with prior work on machine learning to predict extubation failure, which suggests that these features are relevant and is additionally useful for assessing like which features might be included in a next generation readiness exam. The models that we trained did not match the state-of-the-art models in terms of their performance, especially the sensitivity of our models was much lower than these state-of-the-art models. However, these were trained on populations that were collected prior to the onset of the COVID-19 pandemic. So it's possible that there are some differences in the patient population that have resulted in poor performance among this particular cohort. So this is ongoing work, and some of the next steps that we are going to conduct in our analysis is beginning to take advantage of the clinical note data that we have available. So we've been working with our clinical collaborators to identify features in respiratory therapy notes that we have available. So we are working on applying language models to extract these terms from the clinical notes, and we will add them to our existing models to determine how these might be associated with extubation failure and be able to improve model performance. Similarly, also incorporating language modeling to basically create embeddings of the clinical notes that we have available and use those as supplemental predictors for extubation failure. And then we also plan to conduct further work assessing the differences of patients with and without COVID-19, and more broadly assessing the bias and fairness implications of our model across different demographics to better understand who is being well served by the models that we create. So thank you for listening to this talk. Are there any questions?
Thanks very much. So I don't see any questions in chat. I'm kind of curious about the way this model might be integrated into clinical care, and that also relates to how stable the predictions are over time. Like I could imagine if I'm looking to extubate someone, the model has them in the top risk percentile. Like what would the next step be?
Yeah, so I think once we come to a final candidate model, we'll conduct research working with intensive care unit clinicians to understand how they respond to various forms of model predictions and various forms of like entry of information into their models to, I think, better understand how we want to incorporate the information that we've learned, because there are multiple ways of looking at the modeling work we've done. Like it can be interpreted as a like risk prediction in and of itself, or we can use the models as like essentially a knowledge building exercise to better understand like why are patients in different populations experiencing extubation failure.
Thanks very much. There are a couple of questions in the chat that we do have time for. So here's one from Alison. Given that clinicians are making some decisions about whether to extubate non-randomly, how does that affect the utility of the tool? And how can you tell about people who could have been extubated but were not?
Yeah, so we have very limited ways, or we are very limited in how we can assess these counterfactuals. This is something that we have been interested in as we've been doing research, especially if the existing readiness exam was used to provide additional therapies to a patient and therefore they did not experience extubation failure, then we're trying to basically assess different versions of both like the cohort on whom we're training the models. So for instance, assessing patients prior to the time that they were initially extubated and understanding them as extubation failures, and also using different outcomes. So for instance, assuming that if a like patient did receive this like high risk score from the existing exam, then they were deemed high risk, and essentially comparing performance of models trained on these outcomes to performance of models trained on like the binary outcome of did they experience failure in actuality.
Thanks very much. I'm going to sneak in one more question because I couldn't sneak in Jim's last question. So Jim has a question. I'm curious about if the extubation failures were occurring throughout or if they were periodic, like during periods of high ICU load.
Yeah, that is something that we have not analyzed yet, but that would be a good follow-up question about like where these failure cases are. I imagine that in particular during particular COVID-19 waves that we might see higher rates of extubation failure or different utilization patterns. Thank you.
Thanks very much. And with that, I'm going to hand the microphone back to Peter.
Great. Thanks very much to all the pilot presenters and awardees for some fantastic work done with not a whole lot of resources. So it's really exciting to hear the work. It was exciting to hear some of the preliminary findings, the fact some of the findings have been translated into an R1 grant submission and so forth, showing the Institute is having its desired effect of seeding and fostering this kind of cutting edge research and application.